welcome to NOAHE Round 7, Session 6. I'm Negar Razavilar, and I will be facilitating the session. Please join me in welcoming our presenter, Dr. Mike Paulden. Dr. Paulden is an associate professor at Alberta School of Public Health. His research is focused on developing appropriate methods for the economic evaluation of health technologies. Today's topic is a framework for the fair pricing of medicines. And Dr. Paulden will discuss the impact of high-cost medicines on public healthcare budgets and a framework that has important policy implications for payers who wish to improve population health outcomes from constrained healthcare budgets that consider fair prices for medicines. Before we begin, I'll go over some event housekeeping. Participants will be muted throughout the webinar. To submit any questions during the webinar, please use the Q&A function. A friendly reminder that the Q&A function is different from the chat function. The Q&A answering your questions will be facilitated during the final 20 minutes of the webinar. Thank you again for joining us, and I will now hand over to Dr. Paulden.
Thanks very much, Negar. Thanks for inviting me back to present. I was here just a few months ago in January talking about perspectives, and I'm delighted to be back here today to talk about the fair pricing of medicines. So before I begin, you can see there's a QR code on the slide in front of me. If you wish to download the slides, you can scan that code with your phone. I will also be giving you a link at the end of the presentation for where you can download the slides. Oh. Okay, so before we get started, this is a paper that was published a few months ago. It was published online back in December. So if you're interested in downloading the paper, it's open access. It's available for anyone. You can go to that DOI link at the bottom there. Again, you can get that off the slide deck at the end of the presentation if you're interested. But the paper is out there. And I'll give you a warning, it's a long paper. This is a 10,000 word paper. It will take a while to read. So what I'm going to try to do over the next 40 minutes or so is summarize the paper. Okay. So the way that I think about fair pricing of medicines, I come at it in two different directions here. There's two considerations that are really fundamental for any framework like this. The first consideration is that medicine prices have implications for population health. And for those of you who attended my presentation back in January, you will have seen these slides already. I'm going to go over them very quickly, but this is why the price of medicines matters. When you have a collectively funded healthcare system, whether that is a single payer system or a system funded through insurance, there is a constrained budget. We will assume for the purposes of this presentation that we have a single payer system, this public healthcare system with a constrained budget. And there is a new medicine available that we would like to reimburse. And the reason we'd like to reimburse it is most new medicines provide expected health improvements. Okay, so the patients who receive that medicine, they have better health than they would do under the comparator. And so we would like to reimburse that medicine. However, usually new medicines impose an incremental cost on that budget. Not always, but usually there is a positive incremental cost. And as a result, we need to get those dollars from somewhere. You can't spend the same dollar twice. And so as a result of paying for the new medicine, it is inevitable that there is less funding for other healthcare. And as we all know, we are in a situation right now in Canada where every dollar within our public healthcare systems is being spent. There are many, many other things that we would like to do with those dollars. And when you spend a dollar on a new medicine, it means you cannot use that dollar for other purposes that would improve the lives of patients. You could use that dollar to reduce waiting lists in hospitals. You could use that dollar to improve access to primary care, for example. There's all sorts of things that you could do with those dollars. Just a couple of examples here. This is an article from the National Post back in December. Government data shows that more than 17,000 deaths among patients waiting for life-saving or quality of life procedures. And this is a 5-year high. So we could use those limited public healthcare dollars to reduce hospital wait times, right? That's one possible purpose of those limited dollars. Here's another link from the CMAJ. This article was published last year in the CMAJ. National survey highlights worsening primary care access. And this is a quote that jumped out of me from this article. More than 1 in 5 Canadians, an estimated 6.5 million people, do not have a family physician or nurse practitioner that they see regularly, according to a national survey. That's a dramatic increase since 2019, when StatsCan estimated only 4.5 million people did not have a regular healthcare provider. So one of the many purposes that you could put limited healthcare dollars to would be expanding access to primary care. Okay, and I'm sure that you can think of many, many others, right, that I don't have time to mention today. But all of these other uses, we cannot put these dollars to these other uses if they are being spent elsewhere. So when you spend dollars reimbursing a new medicine, those are dollars that cannot be spent on other purposes. So alongside those expected health improvements, that's the reason we're paying for these medicines, for those expected health improvements, we have to recognize that the incremental costs fall on a constrained budget, and as a result, there are expected health losses elsewhere. Now, under a publicly funded health system perspective, which is the primary perspective that CADTH and other HTA agencies adopt, and I talked about that at length back in January, under that perspective, the purpose of a health economic evaluation is to consider the expected impact on the overall health of the population. And it's really important to emphasize the focus is population health. It is not other considerations such as productivity that you would bring in with a broader societal perspective. Under this publicly funded health system perspective, it's population health. That is the outcome that matters. And I'd like you to imagine that there's a new medicine that provides the expected health improvements shown in green at the top of the screen here. And if the price of that medicine is low enough, then reimbursing that medicine will improve the overall health of the population. We'll have the expected health improvements at the top. We have the smaller expected health losses at the bottom. If we were to reimburse this medicine through our public healthcare systems, we would expect the health gain to exceed the health loss. Reimbursing this medicine would improve population health. But for the same medicine, if the price was much higher, then we have the same expected health improvements, but we have a larger expected health loss. So reimbursing that medicine at a high price would be expected to diminish the overall health of the population. And this is true even though the medicine is effective. All right, the medicine's effective, the patients that receive it, they benefit from this medicine, but those costs fall on the limited budget. There are other things we cannot do that we would like to do from that budget, and there are implications for the health of other patients. Okay, the second consideration is from the manufacturer's side. Research and development for new medicines is expensive. Manufacturing medicines can be expensive. And there are many articles that have been published around this. There's a lot of controversy about how you would estimate the costs of research and development for a medicine. This is one article that was published in JAMA in 2020. There are many others. And according to this article, it says the mean cost of developing a new drug has been estimated to be between 314 million and 2.8 billion. So quite a large range. But I think at least we can agree, I would hope, that there is a significant cost, right? We can argue about where the precise dollar amount is, but researching new medicines is expensive. So as a starting point for this framework, and we're going to build upon this throughout today's talk, but as a starting point, I would propose that a fair price for a medicine is one that, first of all, is low enough that reimbursing the medicine within our public healthcare system is expected to improve population health. Okay, so I'm proposing that it's not fair for the price to be so high that when we pay for it through our public healthcare systems, that diminishes the health of Canadians as a whole, Canadians living shorter lives or lives of worse quality as a whole, right? That would be unfairly high. So it needs to be low enough to improve population health. But at the same time, we don't want the price to be so low that it's no longer profitable and it doesn't encourage research, development, innovation in new medicines. So it needs to be high enough for the medicine to be profitable for the manufacturer. That is a starting point, okay? We have a range here. At the upper point, the upper bound of that range is the point where we're not improving population health. And the bottom boundary of that range is where the medicine is not profitable for the manufacturer. Let's now refine this. Let's build upon this framework. And I'm going to do this in two steps. The first one, I'm going to consider the pricing of medicines independently. And then I'm going to move on to the more realistic scenario where a payer gives a price that they are willing to pay for a unit of health, cost effectiveness threshold, if you like, that applies to medicines collectively, okay? Because there are some more complex considerations that apply in the collective model. Let's start by pricing medicines independently to begin with. And inevitably, in a framework like this, we need to be very clear about the assumptions that we're making. So what I've done in this paper is I've laid out a number of simplifying assumptions at the beginning. And then I return to each of these later in the paper and talk about how relaxing each of these assumptions in turn would impact the results. So we're going to try and get this framework as simple as possible from the beginning, and then later we'll talk about what happens when you relax these assumptions. So we're going to assume that the perspective is that of the publicly funded healthcare payer. So that is consistent with the reference case used by CADF, by NICE, by many other HTA agencies internationally. Given this perspective, we will assume that the objective of the payer is to improve population health outcomes. And the implications of adopting a broader perspective, like a societal perspective, or a different objective, maybe it's not maximizing or improving population health, but maybe it's equity-weighted population health. Those are considered later in the paper, but we'll keep things simple for now. The next assumption is that medicines have a single indication, and that within this indication, patients are homogeneous. And that means that the incremental benefit of a medicine will increase in proportion to the quantity supplied. Now, again, this is a simplifying assumption, and it's returned to later in the paper. We also assume that medicines have marginal net budget impact. What marginal means is that the net budget impact is not really substantial in the grand scheme of the public healthcare system, such that it would displace not just marginal technologies, but many other technologies of differing cost effectiveness. That things can get complicated when you have medicines that have a non-marginal budget impact. Treatments for hepatitis C is an example that's often given in the literature. So we will return to them later in the paper. Let's keep things simple for now. Medicines have marginal net budget impact. We'll assume there is a single constrained budget. Again, in reality, healthcare systems can have multiple different budgets, different budgetary silos. That can complicate things. We'll return to that later. We assume that manufacturers incur substantial costs of production and that they will not supply to the health system at a loss. And therefore, we're going to assume, keep things simple, there is a single minimum price at which a medicines manufacturer is willing to supply to the healthcare system in question, hereafter referred to as the reserve price. And of course, that price could be different for different healthcare systems, right? It's probably a different price in Canada as it would be in a developing country, for example. Now, the reserve price, given the effectiveness of the medicine, implies a corresponding reserve ISA. So that is the ISA when priced at the reserve price. So if you figure out what the reserve price is for a medicine, you figure out what the incremental benefits are of that medicine, you can calculate what the reserve ISA is. And if the manufacturer won't supply below that price, well, then they also won't supply at an ISA below that reserve ISA. And then the last page of assumptions for now, manufacturers of new medicines are protected from competition by a time-limited patent monopoly. And the reason this is important is that it allows manufacturers to raise prices above those required to cover marginal costs of production. So this is not a perfectly competitive market where prices would go to an equilibrium at marginal cost of production. That's not the case here. However, that patent protection is time limited. And the time-limited nature of the patent protection raises dynamic considerations that are considered later in the paper. What happens when the drug comes off patent protection, generics enter, and the price falls later in the drug's life cycle? We talk about that later in the paper. So for now, we just assume a single price. Okay, so given all these simplifying assumptions, we can look at the demand curve and the supply curve. So this framework is rooted in kind of basic economics, kind of Econ 101 for those who've done microeconomics. We're looking at the demand curve, the supply curve, and we're looking at the economic surplus that arises at any given price. So the demand curve plots the highest price that the payer would be willing to pay for any given quantity of the medicine. Given the perspective and the objective that we adopted a few minutes ago, the objective is to improve population health. The demand curve is plotted at the price at which there is no population health impacts from reimbursing the medicine. Now, at that price, there's a really interesting result that we have, which is that the ISA of the medicine equals whatever the marginal cost is of producing a unit of health within the healthcare system in question. And in most of the literature, we give that the letter K. You might see papers that refer to this as the supply side cost effectiveness threshold. Okay, so that marginal cost of producing a unit of health within the healthcare system in question, and it will vary by different healthcare systems, If the ISA equals that, well, then that is where the demand curve would be plotted. So here is a figure taken from the paper. And first of all, let's look at where the price is P1. So that's where the demand curve, D1, and we label it D1 because we consider many different demand curves throughout the paper. We label them D1, D2, and so on. So this first demand curve that we're going to look at is D1, and it's plotted at a price of P1. Now, in most textbooks, you see a demand curve having a downward slope, and you do indeed find that when you relax some of the assumptions that we talked about earlier. When you start relaxing that there's a non-marginal budget impact, for example, well, then you'd have a downward sloping demand curve. When there are multiple indications, well, again, the demand curve will be sloping down. But when you have a very simple model, you would have a flat horizontal demand curve like you would here. Now, if the price is lower than P1, let's say P2, then the price is below the demand curve, and the region between the demand curve and the price, bounded between the vertical axis and the quantity, that green region on this graph, that's what we call the consumer surplus. And the lower the price, the greater the consumer surplus. If the price were to be pushed up all the way to P1, so that the price were to overlay the demand curve, well, then there wouldn't be any consumer surplus. What that means is there's no population health gain. In this model, because the objective is to improve population health, the consumer surplus is synonymous with the population health gain. Okay, so this price that's below the demand curve results in positive consumer surplus. And the nice thing about this is that we can explore what happens when you have medicines that are more effective or less effective, what happens in different countries that might have different levels of healthcare expenditure and different values of K. So all else equal, if you have a more effective medicine, then the price at which the ISA will equal K for that healthcare system is going to be higher. So we have a higher demand curve, D2, where a medicine is more effective. And if a medicine is less effective, well, then we'll have a lower demand curve of D3. So a fair price, the upper limit of a fair price for a medicine, will be higher when the medicine is more effective, all else equal, right? Which is exactly what we would expect. The other thing is, if you are in a wealthier country, typically you'd have greater per capita healthcare expenditure, and you would usually see a greater value of K. The empirical work that has been done to date around the world has found much higher values of K in wealthier countries than they have in developing countries. And so this framework allows for higher prices in countries that can afford to pay higher prices, and it would have a lower limit on what a fair price is in countries that have less ability to pay high prices for medicines. Right, so developing countries where the value of K is lower, the upper boundary of a fair price is going to be lower in those countries than it will be in developed countries. Okay, so this framework takes into account the differing effectiveness of medicines, and it takes into account differences in affordability across countries. So what is that value of K? We've talked about it kind of conceptually, but what sort of numbers are we talking about? And as I mentioned, there has been some empirical work done around the world on what that value of K is, the marginal cost of producing a unit of health within a healthcare system. This systematic review was published a couple of years ago in Pharmacoeconomics. I was a co-author on this paper, and it studied a number of papers from around the world. And a couple of years ago, I did some work for Cardiff where I took the results from that review and I converted them into Canadian dollars in order to look at what would it be in Canada. Unfortunately, there's been no published work in Canada done to date. So what does the work that's been done in similar countries to Canada, what does that imply about what K would be in Canada? And by similar, I'm talking about only those countries that are on the PMPRB 11 list of countries that are considered similar to Canada, and the studies that have been done in public healthcare systems. So there's just 4 of them that were in this systematic review. The first was published in England, and that was about £13,000 per QALY in 2008 pounds. What that means is, given the state of the healthcare system back in 2008, the authors estimated that within England's National Health Service, an additional £13,000 added to the NHS budget would be expected to produce another QALY. And conversely, if you took £13,000 out of the budget, you would expect to lose a QALY. Now, if you keep the budget fixed, but you spend £13,000 on a new medicine, well, then you've reduced your expenditure on other services within the budget by £13,000. And so again, you'd expect to lose a QALY. So you need that new medicine to provide at least one QALY for every £13,000 in order for it to improve population health. That's the logic behind this. The next study was from Spain. That was about €25,000 per QALY. There was a study done in Australia that was about 28,000 Australian dollars per QALY. And then one done in Sweden that was about 180,000 Swedish krona per QALY. And if you take those estimates and you convert them into Canadian dollars, you adjust for inflation, you adjust for purchasing power parity, you end up with estimates that are all below 50,000. The Spanish one is the closest to 50,000. The others are quite a bit below $50,000 per QALY. The median is in the region of $30,000 per QALY. So that's the kind of ballpark that we're talking about. As I've said before, we need to do this kind of work in Canada before we have a definitive estimate for Canada. But this gives us an idea of the sort of ballpark we're talking about. Okay, so that's the demand curve. Let's now move on to the supply curve. The supply curve plots the lowest price that a manufacturer would be willing to accept when supplying any quantity of medicine to the healthcare system in question. And those last few words are quite important. The healthcare system in question, it could well be a higher price in Canada that a manufacturer would be willing to accept than in a developing country, for example. And plotting the supply curve is challenging. It's a function of many factors, including marginal costs of production. So a basic result from microeconomics would be that the manufacturer is not going to supply if the marginal costs of production are not being met. If they're making a loss on every medicine they supply, that's obviously too low. But I think the supply curve is actually above marginal cost for a number of reasons. One of them would be reference pricing in other jurisdictions. Okay, so if other jurisdictions are looking at prices in Canada for reference pricing, then it's quite possible that a manufacturer might not be willing to supply Canada at a price, even if it meets marginal cost, if it means that there would be a lower price in another jurisdiction as a result of reference pricing. Okay, reference pricing is extremely complicated. That's obviously a simplification, but I do think that reference pricing would significantly impact on the supply curve, particularly in Canada. And so there are a number of different considerations, and also the payer does not observe this. The payer does not know what the marginal costs of production are, what the implications are for reference pricing. Okay, so there's an asymmetry of information here as well. Although the payer is very clear about the demand curve, or can be, they can specify what that threshold is, if you like, that K value. There is an asymmetry information with regards to the supply curve. So there's a key result here that comes from this, which is that the upper bound of the range of fair prices is a price corresponding to the demand curve. Okay, so in general, let's be clear, there are some medicines where this would not apply, and I'll talk about them later. But in general, there's going to be a range of possible fair prices. The upper bound is the price corresponding to the demand curve, and at that price, at that upper bound, the ISA will equal K. And at that price, there is no population health gain from reimbursing the medicine. Every QALY gained by the patients that receive the medicine is displaced by one QALY foregone elsewhere within the public healthcare system. That's the upper bound. The lower bound is determined by the supply curve, and it's the point where there's no return to the manufacturer. There's no producer surplus. Okay, and there's going to be no profit for the manufacturer. And we have to think, well, is there going to be an incentive for the manufacturer to actually develop that medicine, to supply that medicine? Okay, so that's the range of possible fair prices. We're going to continue refining this, but this is where we're at so far. So here's a possible example. P1 shows the demand curve, just like it did before. P5 is the price, and P6 shows the supply curve, which is a dashed line, which we've plotted here as sloping upwards. It's dashed because the payer doesn't observe the supply curve. But at a price of P5, there is both consumer surplus and producer surplus given the quantity of Q1 provided. Okay, if that price was higher, if the price was increased to P1, well, then all of the economic surplus would go to the producer. And if the price was lower, well, then all of the economic surplus would go to the consumer. So price of P5, the economic surplus is shared between consumers and producers, just as it would be in a model of perfect competition from basic microeconomics, even in a basic model of monopoly. So for those of you who've gone through Econ 101 and you've got your model of perfect competition, and then you assume a monopoly, and the monopolist will lower the quantity, raise the price. Even in that model, there is positive consumer surplus. Okay, so we would expect to see that here for a fair price for a medicine. Okay, I'm now going to move on to step 2, which is pricing medicines collectively. And this is my favorite part of the paper because it's where we start to bring in a bit of the strategic behavior you would expect to see in practice when pricing medicines. So we're going to assume that the payer specifies publicly and transparently a maximum common price for a unit of health, lambda, right? You could call this a cost effectiveness threshold if you like, although that language is a lot of people don't like that language. So this is a common price for a unit of health, right? Every QALY that is provided by the medicine, the payer will pay that common price. Okay, and if you don't like the QALY, well, you can replace it with any other unit of health. The framework will still apply, regardless of the unit of health. And the assumption here is that medicines with a reserve ISA that is less than or equal to lambda, that common price, will be supplied and will be strategically priced so the ISA equals lambda. Okay, so for example, if lambda is $50,000 per QALY, and if there is a medicine that has a reserve ISA of $40,000 per QALY, well, then the assumption is that that medicine will be supplied, but the manufacturer won't price it so the ISA is 40,000. The assumption in this framework is that they will price it so the ISA is 50,000 because that is the maximum willingness to pay of the payer. And in practice, this equalization of the ISA with the threshold can arise from a number of different for a number of different reasons. One of them would be manufacturers pricing up to lambda. Another one, which I think we see in Canada, is setting a higher initial price and then negotiating down to lambda. Okay, so you often see CADIS doing an economic analysis, finding that the ISA is higher than 50,000. CADIS will say there needs to be an X% price reduction in order for it to be cost effective, and then the PCPA can negotiate a reduction in that price. Okay, so it could be that you have a high initial price and it's negotiated down to whatever that common price, that cost effectiveness threshold is. And then a third way this could arise would be if you had value-based pricing and you just explicitly offered a price of lambda for each QALY provided. Okay, well, in that case, the ISA will by definition be equal to lambda. So I think there's a few different ways in practice by which you would end up with ISAs that are close to lambda. Obviously, in practice, there will be some discrepancies. There'll be some prices some ISAs that are lower. But if the ISA is lower than lambda, then it's a missed opportunity for the manufacturer. They could get more profit by raising the price, and so the ISA equals lambda. Okay, so and then we have a very, very simple example in the paper. So this hypothetical example of just 4 medicines, keeping the numbers simple. We'll assume that each of these 4 medicines provides a different number of QALYs and has a different reserve ISA. So medicine A provides 30 QALYs and the reserve ISA is £2,750. The reason we're using pounds here is the UK has the best evidence internationally on what K and V should be. K being the marginal cost of a QALY, V being the marginal value of a QALY, which I'll explain in a few minutes. So that's why we're doing a UK-based example, because they have the best real-world data. So B provides 60 QALYs, but it has a higher reserve ISA. So that higher reserve ISA means if the payer were to set the threshold, that common price, very low, so below £7,000 per QALY, well then treatment B just won't be launched. Right? The manufacturer will say, I'm not making a profit off this. I'm not going to launch the medicine. Once the payer raises the threshold to above 7,750, well, then the manufacturer will supply the medicine and they will price it up to whatever that common price is. And then C and D provide 45 QALYs and they each have higher reserve ISAs. Okay, so we're going to assume that K is £15,000 per QALY, which is similar to recent empirical work that's been done in the UK. Those estimates are in the region of £15,000 per QALY. We're going to assume that the value of a QALY, V, and let's be clear about what that's used for. Once you've calculated the population health gain, right, the gain and the loss, so you have the net population health impact, you can use V to convert those health outcomes into monetary terms. And the reason that's important is you can then compare the consumer surplus, the monetary value of that consumer surplus, to the producer surplus. And then you can calculate the total welfare. So that's why V is important. And we're going to use 30,000 and 60,000, which are values that are used by the Department of Health in the UK. Okay, so I'd like us to imagine what happens to the consumer surplus when you change the common price, when you change the threshold. Because there are many authors, myself included in the past, who have said, if you want to maximize population health, you need to set the threshold equal to K, equal to that marginal cost per quality. And that is true if there is no strategic pricing. If you have a whole bunch of different ICEs for different medicines, and you were to say, right, I know what K is, we're going to accept all of the medicines with ICEs below K and reject all the ones with ICEs above K. And if those ICEs don't change in response to you specifying what that threshold is, then this would maximize population health. However, if the payer is specifying what their threshold is, and then manufacturers are pricing up to that, or setting a high price and negotiating down to that, then it will not maximize population health. In fact, the population health impact will be zero. If every medicine is priced at K, then every quality gained will be exactly displaced by one quality foregone. So it's really important to think about in this dynamic model, what happens when we change the common price or the threshold. So let's start with a ridiculously low threshold that no one would suggest, which is to have a threshold of £0 per quality. And the reason that this is a problem is none of the medicines are going to be supplied because you've not met any of the reserve ICEs. So if you had a threshold of 0, as indicated by the grey circle on this figure, right, at the origin of the graph, well, then none of these medicines are going to be reimbursed. But there's no health gain, but there's also no health loss. There's no opportunity cost either. So the impact on population health, the consumer surplus, is just 0. Now, what happens, starting from this extreme position, what happens if you increase that threshold, let's say to £5,000 per quality? So this is still a very low threshold, right? It's too low, and we'll see why it's too low in a minute. But this is a very low threshold, and only treatment A will actually be supplied at this threshold because the reserve ICA has been met. And treatment A will be priced up to £5,000 per quality. And when it's priced at £5,000 per quality, it provides a health gain of 30 qualities and a health loss of 10 qualities. Okay, and all the calculations for this are given in the paper if you're interested in working your way through all the different algebra, all the different costs. I don't have time to get into all the calculations right now, but there is a health loss of 10 qualities. And so this means that treatment A provides a net population health gain of 20 qualities. But B, C, and D, they're not provided. The threshold is just not high enough. Now, what happens if you were to raise the cost effectiveness threshold to £10,000? There are two countervailing effects of doing this. The first, and this is a good, from the payer's perspective, this is a good thing, treatment B is now provided. Right? Treatment B has met its reserve ICA, and it's provided, and it is priced up to £10,000 per quality. And at that price, B provides a health gain of 60 qualities. There is a health loss of 40 qualities because the incremental costs fall on the budget. And for every £15,000, that's what K is, you lose a quality elsewhere. So there is a health loss of 40 qualities, but there's still a net gain from B of 20 qualities. So that's a really good thing that B is now supplied. But the negative from the payer's point of view of raising the threshold is that A is now priced up to 10,000 per quality instead of 5,000. So the health gain is the same, it's still 30 qualities, but the health loss with A has gone from 10 qualities up to 20 qualities. So the net gain from A has fallen. Okay, but still, when you add A and B together, you have a net consumer surplus, a net gain in population health of 30 qualities, which is more than you got at 5,000 per quality. So raising the threshold at this point improved population health. Right, this is a good thing to do. What happens if you were to raise the threshold again to 15,000? Well, treatment C is now provided, but the problem is that C, B, and A, all of them, are now priced up to £15,000 per quality, which is K. And at K, every quality gain is exactly displaced by one quality foregone. So A provides 30 qualities, but there's a displacement of 30 qualities. B provides 60, but we forego 60. C provides 45, but we forego 45. So the consumer surplus, the population health gain here, is actually 0. And if you were to go further and raise the threshold to 20,000, well, now there are two problems. One is that all of the treatments, well, I say two problems. There are two impacts on population health that are both negative. One is that treatment D is now supplied and it's priced up to 20,000 and the health loss is greater than the health gain. Right? So although the patients who receive treatment D will benefit, it's good news for them, the price is sufficiently high that there will be a bigger loss by other patients. But the other thing is that A, B, and C are now priced up to 20,000 per QALY, and at that price, all of those treatments are foregoing more health than they gain, right? And so we're losing health of all of these four treatments here. The consumer surplus is now minus 60 QALYs, which we actually can't see on this graph, but if we zoom out, this is the graph that's in the paper. You can see that it's right down there at the bottom. But you can see there's an interesting shape to this graph. In general, it's going to start at the origin, it's going to go up, and then it will come down and cut through the x-axis at K, and then it will become negative. So the question is, if you want to maximize population health, where does that curve peak? Right, that's the question. What about from the manufacturer's point of view? So I'm just showing, just because of time, we only have a few minutes left. From the manufacturer's point of view, if you have a threshold of 0, well, then there's no profit. No drugs get supplied. There's going to be no profit. And as you raise that common price, that threshold, when you raise it to 5,000, A will be supplied, priced up to 5,000, and there'll be a small amount of profit for the manufacturer of A. As you go up to 10,000, the profit will unambiguously increase. It's not like the consumer surplus that goes up and down. The profit will increase as an increasing rate because B will be supplied and will be profitable. A will be priced up to the higher threshold and will be even more profitable than before. And then you raise the threshold again to 15,000. C is supplied and is profitable. A and B are more profitable than before, and so on. Right. So the profit, the producer surplus, unambiguously increases as the common price increases. And so this is an idea of, in general, what you would expect these curves to look like. And of course, the exact shape will depend on the characteristics of the health system in question, the specific medicines that are available, the reserve prices for those medicines. There's a number of different variables. But a couple of things we can say are that this consumer surplus will cut the axis at K, right? So far from K being the threshold that maximizes population health, when manufacturers price up to the threshold, or we negotiate down to it, actually there's no population health improvement. We need to have a policy threshold, a common price that is lower than K. In this particular figure, it's lambda C. That is the common price that maximizes consumer surplus. The producer surplus unambiguously increases. And if you were, as a policymaker, you might not be interested in just maximizing population health. We've assumed that that's the objective of the healthcare payer. But as a government, perhaps you're interested in both population health and the health of the domestic pharmaceutical industry, right? So you might be interested in the total welfare, right? The consumer surplus plus the producer surplus. It might be more complex than that. And I actually got into a debate with a professor from the UK in the letters that are attached to this article about, what about if a country is interested in its domestic manufacturing capacity, but not internationally, and some of the producers are international and some are domestic, and so you could have a domestic producer surplus curve if you wanted, and then you'd consider the sum of the consumer and the producer surplus. And that will generally have a maximum that is at a higher threshold. So higher than lambda C. That's where lambda max is on this figure. But the final thing I'll say about this figure before we move on is, would the maximum total welfare always be less than K? Or are there cases where it could be greater than K? And it all depends on the relationship between K and V. So that relationship between the marginal cost of producing a QALY and the marginal value that's placed on a QALY. And there are some good reasons, which I get into in the paper, and we can talk about it during the discussion if anyone's interested. There are some good reasons for why K would be lower than V in practice. And so where K is lower than V, you'll see what you see on this figure here, which is that lambda max is below K. If K is bigger than V, well, actually lambda max would be above K. It would be a different shape, and you'd maximize total welfare at a common price above K. And if they were to equal, if K and V were to equal, well, then lambda max would be at K. But in general, I think there are good reasons why K would be lower than V. So that's why it's been plotted in that way. We just have a couple of minutes left here. I'm going to talk about return on investment. Because one of the limitations with a supply curve and producer surplus is that it doesn't consider fixed costs, including R&D costs. Okay, it only considers those costs that change as the quantity changes. And manufacturers incur substantial costs and risks when developing new medicines. They incur the costs of medicines that fail during clinical trials. And investing capital in developing medicines has an opportunity cost itself, right? You often hear health economists talking about opportunity cost in terms of the public payer, and there's an opportunity cost in terms of health foregone. Well, from the manufacturer's point of view, there's an opportunity cost to investing in a medicine because you could take that capital and invest it elsewhere and generate returns elsewhere. So it's entirely reasonable for the manufacturer to expect to get a fair return on its investment. So it's not good enough for the profit to be just, tiny. There actually needs to be a fair return on this investment. There needs to be a sufficient share of the total welfare to cover fixed costs and enough surplus to reward the risk taken in developing the medicine. And this is particularly important for orphan drugs, other drugs that have a small target population for which the development costs must be recovered from fewer patients, and for which R&D may be riskier. Now, if we're going to talk about risk, we also need to look at the payer, because the payer also takes risks when they reimburse medicines. The health gains and the health losses in any economic evaluation that CADTH would consider are uncertain. And what that means is there is substantial uncertainty as to the net impact of reimbursing a medicine upon population health. And so I think that reimbursing a medicine should be considered as a risky investment by the payer. There are some sunk costs that are made when a medicine is reimbursed. And because the broad purpose of a public health system is to improve the health of the public, the return on this investment shouldn't be considered in dollar terms, but it should be considered in terms of population health, right? So when a public payer invests in a new medicine and there are positive incremental costs, the payer is giving up the opportunity to use those dollars to improve the lives of other patients. And this is a risky investment. There's a possibility that they won't get the return that they're expecting. And a pharmacoeconomic model can be used to estimate the health gains and losses, discounted to a present value. The probabilistic analysis can be used to consider the payer's risk. And the payer's return should reflect that risk. Okay, where there is a greater risk, there should be a greater return for the payer. And the definition of a fair price can be refined to reflect this. So I think the payer should be allocated enough of the economic surplus to cover its fixed costs and enough additional surplus to reward the risk taken in reimbursing the medicine. So in other words, a fair price is one at which the consumer surplus is sufficiently positive, not just positive, but sufficiently positive to provide the payer with a reasonable rate of return on its investment. And I'll stop in just a moment for questions. But this allows us to think about, well, what would a single fair price be within that range that we've talked about? And a fundamental principle of financial economics is that a risky investment requires a positive expected rate of return. And a greater risk requires a greater expected rate of return. And so one way of thinking, well, where in that range should we settle? Well, we've talked so far about a range of fair prices. Should it be towards the top of the range? Should it be towards the bottom of the range? And I would say, well, we need to perhaps think about equalizing the risk-adjusted rates of return for both the manufacturer and the payer. And what this would mean is that the party that incurs the greater risk would get a greater nominal return. So for example, if the manufacturer incurs a greater risk in developing the medicine than the payer incurs in reimbursing the medicine, well, in that case, a greater proportion of the economic surplus should be allocated to the manufacturer. And the advantage of this approach is that it would reward manufacturers who come to market with higher quality evidence, since this would reduce the risks faced by the payer. So as a manufacturer, if you invest the money in a really high quality clinical trial, well, that reduces the payer's risk. And I think that manufacturer should be rewarded through a higher price. They should get a higher proportion of the surplus. And that would incentivize higher quality trials. Like right now, given the methods that are used for economic evaluation, this assumption of risk neutrality, we can get into this discussion if we like, there's no reward for the manufacturer for doing that higher quality study, at least not in the economic evaluation. And then one of the final things I'll say is around dynamic pricing. So as I mentioned earlier, one of the complicating factors here is that a medicine is very unlikely to have just one price over its life cycle. You would expect the price of a medicine to fall after patent expiry when it's subject to generic competition. But the price of the comparator might also change over time. What if the comparator is under patent protection, but that expires before the new medicine? Well, then the incremental cost of that new medicine might increase in the medium term when the patent is subject to generic competition, when the comparator is subject to generic competition, but then it might fall in the long term when the medicine is itself subject to generic competition. So things can get complicated when you think of dynamic pricing, not only for the treatment in question, but for the comparators as well. And also when you take into account possibility of evergreening and other strategies that might be used, it might be that the number of patients who would receive this medicine in future years after it comes off patent protection might be smaller than it would be today. And in my view, the economic model, where possible, in principle, should reflect that. A fair price should, as far as practicable, be established over the entire life cycle of the medicine, taking into account these dynamic considerations. And by doing that, if your ISA actually reflects these dynamic considerations, well, at that point, it becomes unambiguous that that ISA needs to be below K in order for there to be a population health improvement. Because one argument that could be made, if you have a static model and you just use today's price, you could excuse an ISA that is above K on the basis that, well, yes, we're foregoing population health today, but one day this drug will come off patent protection, we'll have lower prices, and we'll gain population health in future. So it's okay to have an ISA above K today. And a response to that would be, well, let's model that. Let's actually model the probability of having a lower price in the future. And once we've done that, once the ISA has reflected that, well, then there is no excuse for having an ISA that is above K, because it means that over the life cycle of the medicine, we would expect population health to be diminished. And then very, very quickly, further considerations. I won't go into detail now because of time, but if you're interested in these, in the paper, I talk about, what about medicines with no fair price? What if there's a medicine that has such a high marginal cost of production or a relatively small incremental benefit, and the supply curve lies above the demand curve, right? There is no range of fair prices. What do we do about those medicines? What happens when we relax the assumptions that we made earlier? So what if there are multiple indications and heterogeneity? And when you have multiple indications, that demand curve can kind of step downwards, like a step function. What if there's non-marginal net budget impact? Well, in that case, the demand curve will slope down. The greater the quantity supplied, the greater the budget impact, you would expect the demand curve to fall. And that would be reflected in a lower upper limit on a fair price. What if there are multiple budgets or budgetary silos? Well, then in theory, you could have a different K for each budget, and that's going to have implications. What if there's a societal perspective or equity weighting? Well, again, that's going to make some medicines relatively more valuable, right? If they provide societal benefits, or there are populations that benefit that are subject to equity weighting, but it's also going to impact our consideration of opportunity cost. You now need a societal opportunity cost. You need to equity weight the opportunity cost. So there will be some medicines that appear less cost effective. But this framework will still apply. You just have a different objective in that case. And also the dynamic impacts of innovation. So maybe it's worth paying a higher price today and giving more producer surplus over than you might otherwise think is optimal, because that producer surplus gets invested in future R&D, and we get new treatments developed as a result, which provide us more consumer surplus in the future. Okay, and there is some work going on right now at the University of York, some empirical work that was just published actually, and it's looking at what is the optimal share of that economic surplus? How much should go to the producer? How much should go to the consumer in order to maximize population health over the long term? Right. So to a point, giving more of the share to the producer will get invested in future R&D, but that's only to a point. And the point that I make in this paper is it would justify a higher threshold when you're pricing collectively, but not a threshold above K, because once you get above K, then you're paying such a high price today that you're diminishing population health. And even if it encourages future innovation, those future innovations, they'll be priced above K and will also diminish population health. So at that point, you've gone too far, but it would justify a higher threshold within that range, somewhere below K. So very quickly in summary, we've proposed a framework to support the determination of fair prices for medicines. The framework attempts to strike a balance between the interests of patients and the interests of manufacturers. The framework makes 3 departures from convention, which I think have important implications for the fair pricing of medicine. So the first departure is that, unlike previous papers, including my own papers from the past, we do not consider K and V as competing approaches for defining a common price for a unit of health or cost effectiveness threshold. There are papers that talk about what should our threshold be. Should it be K or should it be V? And what I'm proposing here is neither, right? K, both are important. K is a component of the medicine's demand curve, and that allows for estimation of the consumer surplus. V is used to value the consumer surplus in monetary terms, so we can calculate the total welfare. But once you've done that, you then need to think about, well, what is the fair share of that surplus between producers and consumers? And that's going to determine your policy threshold in practice. It's not necessarily K or V. The second departure this framework makes is this relationship between the common price offered by the payer and the resulting ICEs of medicines. So this strategic pricing to the threshold or negotiating down to the threshold. Where medicines are priced collectively, the payer must take this into account. And if you want to maximize population health or maximize total welfare, you need to have a threshold that's lower than K in order to do that, when you consider the strategic pricing as well. And then finally, the framework recognizes that reimbursing medicines is a risky investment by the payer, given the often substantial uncertainty regarding the expected impact on net population health. And conventionally, research on return on investment focuses on the manufacturer. And I think we need to expand that, recognize that the manufacturer needs a reasonable rate of return, recognize this is a risky investment for the payer, and the payer deserves a reasonable rate of return, and think about what a fair share of the total economic surplus would be between the payer and the manufacturer. And if anyone's interested in this, you can download these slides from the URL or from the QR code there. And as I said, the paper itself is open access, so anyone can download it and read it. So thanks very much for listening.
Thank you very much, Dr. Paulden, for the fantastic presentation. We have a few minutes for Q&A, so we encourage the attendees to use the Q&A function to ask their question. And for your information, today's presentation is being recorded and will later be posted on the NOAA website on the past events page, like any other NOAA presentation.
I know there's a lot to take in. It's a 10,000 word paper in it's about 50 minutes in the end, not 40 minutes.
So we do have a couple of, oh, sorry, Mike, I didn't mean to interrupt, by the way.
Sorry, go ahead. Q&A.
Yeah, we do have a couple of questions from Sasha. So the first one is, so read the single quote unquote fair price. The first question is there a temporal bias in the risk facing the producer and purchaser? The producer is making investments at the R&D stage, so they are making risk-based choices well before the purchaser driving their reserve price. So how are these two agents meant to arrive at a balance to a quote-unquote fair share surplus if the decisions by each agent driving prices are happening at different times?
Yeah, that's an excellent point, Sasha. And it's not just that there's different times as well, there's the asymmetry of information. And I don't think that both parties would agree upon the risk, the calculation of the risk, right, that each would face necessarily. So I agree that calculating this in practice would be extremely difficult. So this is a kind of a conceptual, within this range, where do I think, the optimum would be? But I agree with you that there's that it's going to be extremely difficult to calculate.
Thank you very much. And the second question is, isn't the risk-based pricing by the purchaser already an incentive to the producer to provide higher quality evidence due to lower uncertainty and therefore lower risk?
Yeah, I agree. Yeah, absolutely. Yeah, so this framework's trying to kind of solidify that, that it's fair. It's fair to offer a higher price to a manufacturer that comes to market with higher quality evidence because it benefits the other side. Yeah.
Thank you. And we have a question from Mehdi. He's asking, hi, Mike, what are other factors considered for ROI in your study?
From the manufacturer side or from the healthcare payer side? From the From the healthcare payer side, that's the side that I think has been neglected in the literature. And so I do provide a list of some of the costs that are that are sunk costs, right? That the payer would not expect to get back if it turns out that the medicine is not as effective as expected. So so from the manufacturer side, so I think the primary consideration is going to be that opportunity cost, as I mentioned, that the manufacturer could take the capital that they're putting into developing the medicine. They can invest it in all sorts of different things. And so you need to ensure that the rate of return is greater than that opportunity cost, or else there's going to be no investment in the new medicine. The real challenge comes, I think, where in order to provide that sort of rate of return, you would need to have such a sufficiently high price that it's no longer considered fair for the payer, right? So once the price gets sufficiently high, that there's no population health gain. Those are the really challenging cases, right? It's like, what do we do where there is no fair price? Where if you have a price that's high enough to provide enough producer surplus, enough of that ROI for the producer, well, then there's a negative ROI for the payer. And vice versa, right? In order for there to be a return for the payer, there would be a negative return for the producer. And what do we do in those cases? And I do talk in the paper about, some potential approaches, which would be to identify those medicines where that's the case and potentially cross-subsidize them from other medicines where there is a much bigger gap between there's a much larger range of fair prices. Perhaps we could reallocate some of the surplus from other medicines in order to effectively subsidize orphan drugs, for example, where it might be just impossible to get to a price that would provide a positive return for both. Maybe we wish to cross-subsidize them. But of course, doing that, I think it should be done in a way that the subsidies come from both the manufacturers and the payer, right? It shouldn't just fall on the payer, which is what happens, for example, with the Cancer Drugs Fund in the UK, right, where the payer has allocated a separate fund where effectively you're paying more for a QALY. I think subsidies could also come from manufacturers of blockbuster drugs who get a substantial return, right? So there's various different approaches.
Thank you very much. Thank you very much, Dr. Paulden. We're almost at time, so anyone with further questions after today's webinar is encouraged to email noah@rhe.ca. So thank you very much again, Dr. Paulden, and thanks to everyone online for attending. So the final NOAHE seminar of the current academic calendar year is scheduled for June 19th, 2024, and is presented by University of Calgary's Dr. Reid Beale and Jane Fletcher. Please visit noah.ca to register and subscribe to our mailing list for news on upcoming events. Thanks to everyone for attending, and have a great day.